Hello, everyone. I would like to thank you very much for being here today and to welcome you to today's webinar, Thromboinflammation COVID-19. Together with my colleagues, Carola and Bärbel, we will guide you through the importance of the dimer and coagulation assays in the diagnosis, triage, and follow-up of the COVID-19. So before we start, I would like to go through a couple of organizational issues. Carola, thank you. So first of all, I would like to kindly ask you, if you will have problems during the broadcasting of this webinar, to please let us know by writing in the chat that you see on your right side. For today's webinar, we have planned 30 minutes. In the first 20 minutes, Carola and Bärbel will, as said, will make their presentation, will present you the importance of these parameters in COVID-19. And at the end, the collected answers, once again, through the chat function, will be answered from them. What you can see in this graph here very shortly is an exponential rise of the COVID-19 cases worldwide. Many of us, me too, I believe you, we have hoped that by this time we would have seen a flatter curve, but as you see, it's going always up. And this is why parameters like these are today much more important than ever. Very shortly, this is me. I'm working since 5 years for Oman. By background, I'm a medical doctor, but I'm working since 15 years in sales and marketing in different pharmaceutical and medical devices companies. And here are my two colleagues, Carola and Bärbel.
Hello, everybody.
Carola, the stage is yours.
Hello, everybody. I'm Carola Henche. I'm a biologist from my background. I worked in sales and marketing positions for over 10 years in pharmaceutical and diagnostics companies. And since 2019, I'm the product manager for the hemostasis reagents at Human.
Hello, I would also like to welcome you to our webinar. My name is Bärbel Knaue-Kretschmer. I've been working for Human since 2013, and as the head of the R&D coagulation department, I'm located in Magdeburg. Later in this webinar, I will give you some basic scientific background information about thromboinflammation, about the interplay between inflammation and coagulation. Until then, I would like to hand over to my colleague Carola in Wiesbaden.
The ISTH, the International Society of Thrombosis and Hemostasis, reacted very quickly on the COVID-19 outbreak by releasing guidance documents, for example, by sharing open access educational resources related to COVID-19, and also by pivoting the recent ISTH Congress to a virtual Congress, sharing all relevant publications and talks, which you can see here on the slide. And here you can also find publication that shows in an illustrated review the current study reports that show the relevant parameters in COVID-19. So in a nutshell, the platelet count is mildly to moderately decreased, and especially in non-survivors. But mostly it remains up over 100. The prothrombin time is slightly prolonged in a minority of patients, especially in the non-survivors group. The fibrinogen is typically high, which you can see here. Only in severe cases of COVID-19, shortly before death, it is observed that the fibrinogen levels drops very strongly below 1. Typically, the D-dimer levels are quite high, especially in the non-survivors group. The antithrombin levels remain quite stable. So this clinical and diagnostic picture was also observed in the first Chinese studies that were confirmed and summarized in a retrospective cohort study by Fei Shui et al. The authors concluded by then and identified 3 major risk factors that are critical for prognosis of COVID-19 patients. These are older age, a high SOFA score, which is sequential organ failure assessment, and a D-dimer value that is greater than 1 microgram per liter in fibrinogen equivalent units. As you can see on the graph on the right, is the rising D-dimer levels, especially in the non-survivors group. So obviously there is a new version of coagulopathy that is associated with COVID-19 that differs from other versions of coagulopathy that is observed, for example, for the sepsis-induced coagulopathy or the disseminated intravascular coagulopathy. This is also visible in the clinical picture. With COVID-19, there is much more venous thrombosis, like with DIC and SIC, whereas both coagulopathies have typically microthrombi. The platelet count remains normally quite high for the CAC. The D-dimer is high in both forms of coagulopathy. The PT is just mildly increased normally. Fibrinogen is high and antithrombin levels remain quite stable. So this is also visible in the clinical picture that there's hardly any bleeding observed. Unlike other RNA type viruses like Ebola and hemorrhagic fever viruses, SARS-CoV-2 does not cause bleeding. And also a consumptive DIC with a bleeding diathesis is not common with the CIC. So Bärbel Knauer will tell us now more about this special version of coagulopathy that is associated with COVID-19.
Thank you, Carola. Before I go on with my main topic about thromboinflammation, I will start with a short explanation about D-dimer. A blood clot, as you can see here, consists of cells and a fibrin network. And D-dimer is a specific fibrin degradation product and appears in the blood after a blood clot is degraded by fibrinolysis, which is mediated through the action of the enzyme plasmin. And elevated levels of D-dimer reflect active coagulation processes. Next, please. Now we'll go on with the scientific background about thromboinflammation and what is reported about its connection to COVID-19. The terms thromboinflammation or also immunothrombosis are useful to denote extensive interactions between the body's innate and acquired immune systems with their many immune systems cell types and the coagulation systems with the plasma coagulation proteases. And the healthy crosstalk between circulating proteases and cells is critical for providing the optimal benefits of protective inflammation reactions and protective coagulation reactions and the stabilization of endothelial and vascular functions. And this healthy crosstalk is necessary to combat invading pathogens such as SARS-CoV-2. But in an inappropriate crosstalk between proteases and cells, this can lead to hyperinflammation and vascular dysfunction. Next, please. How important the regulation of the host defense system is summarized in this figure. The host defense systems are the immune system, inflammation processes, and the coagulation systems. And SARS-CoV-2 triggers the host defense systems, which activate each other to attack and help neutralize the virus. In the green box, you can see when the inflammatory reactions and the coagulation reactions are well regulated by positive and negative feedback loops, then the host defense is successful. This results in the rejection of the invader, in our case, the SARS-CoV-2 virus, and the survival of the host. In the red box, we see when one or more of the host defense systems is less responsive or already hyperactivated, then the host defense system is unbalanced. And this can be due to comorbidities such as vascular diseases, hypertension, diabetes, and so on. And the result of the comorbidities can be that the inflammatory reactions and the coagulation reactions are dysregulated and excessive, resulting in death. Next, please. Now let's have a look on the figure from the Journal of Heart and Lung Transplantation, where the author Siddiqui and Mera illustrates 3 possible escalating phases of the COVID-19 disease progression with associated signs and symptoms. On the x-axis, we see the time course divided in the 3 stages, and the y-axis indicates the severity of the illness. And let's go through the 3 stages and their characteristics. Let's begin with stage 1, is a mild early infection. And the initial stage occurs at the time of inoculation and early establishment of the disease. For most people, this involves an incubation period associated with mild and often non-specific symptoms, such as feeling ill, fever, and a dry cough. During this period, SARS-CoV-2 multiplies and establishes residence in the host, primarily focusing on the respiratory system. And the diagnosis at this stage includes, for example, respiratory sample PCR, serum testing, SARS-CoV-2 IgG and IgM tests, blood count, and liver function tests. And in patients who can keep the virus limited to this stage of COVID-19, the prognosis and the recovery are excellent. Next, please. In stage 2, we have a moderate but pulmonary involvement without and with hypoxia. And this second stage of an established pulmonary disease, it is reported a viral multiplication and localized inflammation in the lung. And during this stage, patients develop a viral pneumonia with cough, fever, and possibly hypoxia. And markers of systemic inflammatory systemic inflammation may be elevated. It is at this stage that most patients with COVID-19 would need to be hospitalized for close observation and management. Next, please. In the third stage, this is a severe stage with systemic hyperinflammation. In a minority of COVID-19 patients will show a transition into the third and most severe stage of the illness, which manifests as a systemic hyperinflammation syndrome. And in this stage, markers of the systemic inflammation seem to be elevated. And studies have revealed that inflammatory cytokines and biomarkers are significantly elevated in those patients. These are, for example, the interleukin 2, 6, and 7, the tumor necrosis factor, the very well-known C-reactive protein, and very important, the D-dimer. And overall, the prognosis and recovery from this critical stage of the illness are poor, and a rapid recognition and deployment of a therapy is very important. Next, please. But what is the proposed mechanism behind this hypercoagulable inflammatory stage in COVID-19 patients? Here it is shown in a simplified figure from a report from John et al. The SARS-CoV-2 virus binds to its target using the ACE2 receptor on human cells. And these receptors are abundantly present on the human lung and vascular endothelium. And looking at other systemic inflammatory disorders have implicated the complement pathway, indicated here in blue, in the pathogenesis of COVID-19, and particularly the anaphylatoxins C3A and C5A. And C5A is a very potent signaling protein that activates a cytokine storm and the innate immune response. In addition, C5A is also a potent activator of the coagulation system. And the disruption of the homeostatic interaction, the unbalanced crosstalk between complement and coagulation pathway results in increasing coagulation events in the microvascular of critical organs. And this is what we see in COVID-19, a systemic inflammatory response with a procoagulant state and organ damage with microvascular thrombies in the lung. Next, please. Now let's have a look on the air cells of the lung, the alveoli. The figure is divided in two sides, the left and the right side. On the left, we can see it is undamaged. We have a smooth blood flow, an effective oxygenation. On the right side, it is damaged. We have a COVID-19 infection causes an intense inflammatory reaction. The lung tissue damages are induced by uncontrolled activation of the lymphocytes. And what is also involved in the host defense process is an increased pulmonary activation of platelets. And in the lung, the virulence of COVID-19 causes microthrombi, as you can see here, endothelial damage, and vascular leakage. And the host intends to control the thrombi formation by vigorous fibrinolysis, since the lung has a high fibrinolytic capacity. And the fibrin degraded fragment, the D-dimer, spills into the blood and is detected in the blood samples. Next, please. I would like to end my part of this webinar with the following summary. What is reported about the COVID-19 associated coagulopathy? First, the coagulopathy manifests as an elevated D-dimer level with high fibrinogen and small changes in the PT, APTT, and platelet count in the early stage of infection. We have an increasing interleukin-6 levels that are correlated with increasing fibrinogen levels. Coagulopathy appears due to thromboinflammation and not because of direct viral activity. We have an elevated D-dimer at hospital admission and associated with increased mortality. The rising D-dimer after hospital admission precedes multi-organ failure and DIC, and the bleeding manifestations are not common despite coagulopathy. And now I would like to hand over back to Carola.
Thank you very much, Babel. So how to manage now this new version of coagulopathy? As already mentioned earlier, the ISTH, the International Society for Thrombosis and Hemostasis, released very early guidance documents. Summing up in this first guidance document, they recommend for laboratory diagnostics in coagulation, D-dimer, prothrombin time, and also the platelet count, initially at admission at hospital, and for hospitalized patients once to twice per day. In addition, if a DIC is suspected, also fibrinogen should be considered. And they recommend a prophylactic dose of low molecular weight heparin for all hospitalized patients. As thrombotic complications and coagulopathy is quite common with COVID-19, so prophylaxis with anticoagulants is recommended, as studies have shown that it is increasing the survival rate. There's a preference at the moment for heparin, as there is some evidence that the heparins have an anti-inflammatory effect, and this may have a benefit for the COVID-19 cause. In May 2020, the ISTH released also a guidance document for clinical guidance and the venous thromboembolism prophylaxis in COVID-19 patients. They recommend here to have a routine prophylaxis with heparin, if not contraindicated. Also, an intermediate dose with low molecular weight heparin may be considered, especially as the venous thromboembolism prophylaxis should be adapted and modified based on the risk factors, for example, extremes of body weight, severe thrombocytopenia, and the deteriorating renal function. The treatment dose with heparin should not be considered. Some recent studies indicate that a prophylactic dose with heparin is not sufficient for all patient groups. However, the ISTH is not recommending this until there are the results of randomized controlled trials available. Especially for patients in intensive care units, there are additional and multimodal thromboprophylaxis with mechanical methods. For example, the intermittent pneumonic compression devices should also be considered. The duration of the anticoagulation after release from hospital should be at least 14 days up to 30 days. Also, the WHO has released in May a guidance document on the clinical management of COVID-19. Chapter 11 is dedicated to thromboembolism. As the WHO states that coagulopathy is common in patients with severe COVID-19, and both venous and arterial thromboembolism have been reported. So they also recommend prophylactic doses of heparin, such as, for example, low molecular weight heparin. For those patients with contraindication, mechanical prophylaxis should be used. And they recommend to monitor patients with COVID-19 for signs or symptoms for thromboembolism, such as stroke, deep vein thrombosis, pulmonary embolism, or acute coronary syndrome. Referring to this guidance, the ISTH just recently released a publication, a call to action, in July 15th. They urgently calls on the WHO to endorse and share the application of a system-wide approach to the management of venous thromboembolism. They highlight the importance of a systematic approach to VTE prevention, diagnosis, and treatment for patients with COVID-19. Health worker education should be improved about VTE in COVID-19, and this includes also up-to-date WHO guidances. Signpost hospitals should be accredited to an evidence-based clinical information system, and, for example, like the COVID-19 resource page on the ISTH. And they highlight to member states the importance of making available all WHO essential medicines, in particular low molecular weight heparin, as this is not given at the moment. And they encourage the implementation of a global VTE risk assessment tool for hospitalized patients. Further information you can find on the Human website, like, for example, the fact sheet about hemostasis parameters, and D-dimer overview, and also a fact sheet summarizing the ISDH interim guidances, including a management algorithm. There's a dedicated segment for COVID-19 on the Human website, where you can find, for example, also the current publication list for COVID-19. So I will hand now over to my colleague Dimo for the questions and answers session.
I would like to thank Carola and Bärbel for a very interesting presentation today. Thank you very much. Unfortunately, we are approaching 10:30 much faster than I really thought. So I will answer only one question, which is very important directly here. Well, I will kindly ask you to answer the question, and the other questions we'll answer directly through emails or with the information that we will send out. The most important question that, what is important to me as a person in contact with distributors and customers is if the presentation will be available for them.
Yes, of course, we will share this presentation on a login area, and there where the fact sheet are available. So, and also question and answers will be provided after this webinar.
Excellent. And for the rest of the questions, we will try to come back to everyone in our email together with the presentation. What do you think? Is it okay for you? So
Wonderful.
Once again, I would like to thank you very much for a very interesting presentation. I would like to thank you for participating and wishing everyone to stay healthy and hoping for better times. We are looking forward to welcome you to the next webinar. Thank you very much.
Thank you. Bye-bye.
Bye.
Thank you very much.